All right, last but not least, I'm delighted to introduce to you Professor Catherine Baker. She's a professor of health economics in the Department of Health Policy and Management at the Harvard School of Public Health. Now, when she comes up here, you're gonna, she's gonna look quite young, but don't let that fool you. Dr. Baker was on the Council of Economic Advisors from 2005 to 2007, and the reason why she achieved this level at this point in her career is she does the hard quantitative stuff. She came from a training in public finance, so she's an expert in public finance and taxation, and really is really well worded in terms of what goes on in terms of financial information, and she's used all that training to study sort of the best ways to sort of achieve health insurance and different options for health insurance in this country. And not only that, but she's actually used that information and is also analyzing in some very creative ways how these different types of health insurance approaches influence the quality and outcomes for patients. So with that, I'll hand things over to you, Kate.
Well, I thank you for that introduction and for the opportunity to be here. Mark jokingly complained about his slot, but I have to go after Mark, which seems to me extremely unenviable. I will certainly not speak with more knowledge, and I won't begin to try to speak more quickly, but hopefully I can gesture more wildly, and that will make up for it. So what I wanted to talk to you about is really along the same lines that Mark spoke, thinking about what the prospects for reform are and how we can really achieve higher value care through health system reform. And there are going to be a wide number of policy levers that we might want to consider pulling that'll have really different implications for the distribution of benefits, for the quality of care, for the quantity of care that we consume. I think health reform is firmly on the agenda right now for two reasons. One, the rising ranks of the uninsured, and that's particularly problematic in a system where so much of our non-publicly funded health insurance comes through employers, and people are increasingly worried about losing their jobs. Today, the prospect of losing your job entails not only a loss of livelihood, but potentially a loss of life-saving health treatments, and that's something that's of great concern to a wide group of people and a widening group of people. That interacts with the rising cost of healthcare, and a theme that I'll come back to again and again is that I don't think that those two issues are really separable. Some of the debate focuses on covering the uninsured. Some of the debate focuses on lowering healthcare costs. But those two goals clearly interact. When healthcare premiums rise, fewer people can afford them, federal budgets are strained, private budgets are strained, and when fewer people are insured, you have a degeneration of risk pooling in private health insurance markets and an increasing burden on charity care providers and safety net hospitals such that costs rise more quickly. So I think that we ought to focus policies that address both of those issues at the same time, and each will be more successful that way. Really, the initial motivation for thinking about health reform, though, wasn't just the rising ranks of the uninsured, although that's become more salient recently, but it's the rising costs to the system of providing health care. If you think about the private costs of providing health care, insurance has risen. The cost of insurance has risen at a rate that's much faster than wage growth or than GDP. This is a graph of employer-provided premiums for a typical family policy going back to 1988. You can see that there's a little bit of a leveling off in the 90s that we've talked about with the advent of managed care that really involved squeezing provider payments in a way that wasn't sustainable over the long run. And then costs have continued to rise just as rapidly after that leveling off period. The breakdown in colors that you see is the split between the employer share and the employee share, and that's something I'm going to come back to later. But one thing to note is that that share hasn't really changed over time. It's roughly 30% coming from employees, the rest coming from employers. But what I'll argue later is that that breakdown doesn't even matter. All of it comes out of the pockets of employees in the long run. That growth is much faster than the rising hourly earnings of workers in the country. And what that means is that an increasing share of workers' compensation is coming to them in the form of health benefits. If you had imagined healthcare costs rising at the rate of inflation instead of the excess rate at which they have risen, wages would have risen about 25% more quickly than they did in reality. And that's because employers are using an increasing share of the money devoted to compensation to pay for health benefits. And that is largely invisible to employees. If you ask employees, how much do your health benefits cost? by and large, they tell you their out-of-pocket share. They have no way of knowing how much their employer is contributing to their health benefits. Some employers have started reporting that information on employees' pay stubs, most don't. And so most people don't even know the value of the insurance that they're getting, let alone how much it's worth to them. So it's asking a lot of the system to have an optimal allocation of resources when nobody really knows how much is getting spent on their behalf in the first place. Now, that's private costs. We're all well aware of the strain on public budgets that healthcare financing is exerting. The federal budget is really, in the long run, going to be driven entirely by healthcare costs, and that's Medicaid, which is a jointly state and federally financed program, Medicare, which is 100% federal financed, and this hidden subsidy of private insurance through the tax code. And I'm going to spend a fair amount of time at the end of the talk thinking about how we might want to get more value out of that subsidy. The amazing thing is that that hidden subsidy of private health insurance, because it's not taxed through the federal tax code, is more per year than the federal government spends on Medicaid. That tax expenditure subsidizing particularly inefficient private health insurance costs the federal government more than Medicaid. That to me is shocking. It's an enormous hidden public program, and it's resources that are being spent in a way that is both inefficient and unfair. So that is why I think it's one of the areas that's ripe for reform. If you look at the federal budget, especially going out 50 or 60 years, the growth in federal spending is entirely driven by entitlement programs, Medicare, Medicaid, Social Security. The level that Medicare, Medicaid, and Social Security will comprise out at the end of that graph, around 2070 or 2080, is more than the entire federal budget today. So if nothing changed, that entitlement spending would crowd out everything else that the federal government does, from education to highways to national defense. Now, clearly that's not going to happen. Something's got to give. What's going to give is what we're all debating today. Now, you'll notice that Medicare and Medicaid are growing much more quickly than Social Security. We spent a lot of time 5 or 6 years ago talking about the unfunded liability of the Social Security system, and everybody blamed the baby boom generation and this increasing number of retirees per worker that was going to bankrupt Social Security. The unfunded liability of the Medicare system is 5 times as large as the unfunded liability of the Social Security system. And that's because not only does it face the same demographic pressures that Social Security faces, but we're spending more and more and more per beneficiary on these healthcare programs. So it's not really the number of people, it's the dollars spent per person. And these, again, are CBO graphs from the same source that Mark took his, where you can see that what's driving that increasing share of federal spending on health programs is really excess cost growth per beneficiary, not more beneficiaries. So yes, the demographics are working against us, but that's the least of our problems. So how can we then reform the system to get higher value out of it? Rising costs, those graphs that we just went through, are a big motivator for getting costs under control. It's going to bankrupt us all. We have to do something. See, I wasn't kidding about the gesturing. But that's not, I would argue, the right metric. I can solve our Medicare budget deficit problem in one fell swoop. Eliminate Medicare. So obviously, that's not a good policy because we get a lot of value out of the Medicare system, maybe not on the margin, and we certainly need to reform it. But healthcare spending, on average, is well worth the money. We spend now, pushing 20% of GDP on healthcare, and people say, well, that is just too much. Is that too much? I don't know. When you think about what a country might spend its money on, especially as individuals get wealthier and as economies get wealthier, we expect to spend a greater share of our economy on healthcare. What more would you want to buy than extra years of healthy life? Clearly, if you could buy that with your money, it would be worth giving up a lot of other goods. If we were getting our money's worth out of the system, I would say, great, let's spend 30% of GDP on healthcare. Let's spend 40% of GDP on healthcare. The problem is we're not getting our money's worth, and we're not getting our money's worth on not a tiny share of GDP, but an enormous share of GDP. So I would argue that that's the better metric. The problem with focusing on the cost metric, which is the more salient one and the easier one to measure in a budgetary sense, is that it adds to the allure of cost-saving, life-saving interventions that I would argue are few and far between. Yes, if there's an opportunity to save money and save lives, we should absolutely seize it, no matter what share of GDP we are spending on healthcare. Clearly, everybody's better off if you can spend less money for better health. There are a number of policies we can do that would promote that, but it's pretty quickly going to come down to much tougher choices than that, where we have to decide whether to spend more money to get more life or less money to get less life, or where to spend the money. Whose lives are we saving? What procedures are we financing? So I would hate for the promise of cost-saving, quality-improving interventions to crowd out a discussion that we have to have nationally about really making tough choices. So let's focus on policies that promote value and then think about what the distributional implications are. Who's going to reap the benefits of that? There is ample evidence that we are not getting high value from the healthcare system, and I'm not going to spend much time on that because I think people are pretty well persuaded. You could look at how much the US spends on healthcare as a share of GDP, and we spend much more than other countries, not only in dollars, but as a percent of an even larger GDP. And our healthcare spending is rising just as quickly as everybody else's. It's not like we got to some plateau of spending first and everybody else is catching up. They're not catching up. We're all rising at fairly comparable rates. That should give you a little bit of pause about thinking that it's just the insurance system that's driving it, because countries with very different payer systems are also experiencing big run-ups in their spending. So the payer system isn't the only part of the story. What are we getting for that money? You can look at infant mortality and say, gee, our infant mortality is falling. That's good news, but it's still much higher than other countries. I would be hesitant to use this as all the evidence you need to know that we're not getting our money's worth, because as Janet pointed out this morning, a lot of things go into infant health that have nothing to do with health care. By the time an infant is born with low birth weight and requires a lot of expensive intervention, it's already too late in some sense, or it's at least too late to get efficient quality outcomes for the money that you're pouring into the health care, when prenatal care or other interventions might have done that in a much more cost-effective way. Also, if you look across countries, there are so many inputs into health besides health care. Mark chaired a commission that I also sat on, the Robert Wood Johnson funded commission, to look at things that promote health that have nothing to do with health care. And clearly nutrition, lifestyle, exercise, smoking, alcohol, all of those things have huge impacts on health, that by the time you get to the healthcare system, you may face very different costs. It may be more expensive to treat a US citizen showing up with a heart attack than someone in another country, because that person is coming in with worse health inputs. So this alone isn't good enough evidence. Let's look within the US, and Mark showed you some graphs from Dartmouth. I spent 6 years at Dartmouth, so I am by law obligated to put up a map every talk I give, so check. What this graph shows, what this map shows, is among Medicare patients, ambulatory care sensitive hospital discharges. These are discharges from the hospital for conditions where the person should never have ended up in the hospital. Think about somebody admitted to the hospital with an uncontrolled asthma attack or for a diabetic leg amputation. If the person had received better care out in the community, that hospital admission and subsequent discharge would never have happened. So think of this as a map of a low-quality primary and preventive care. The reason we're looking at Medicare beneficiaries is not because there's something unique about them. Rather, I think a lot of the results from Medicare beneficiaries generalize to the rest of the population. It's a data issue. For these measures, you really want good risk adjusters and comorbidities and individual characteristics, and we don't yet have that for privately insured populations. So a lot of the analysis that we do focuses on Medicare beneficiaries because we have such rich claims data on them. So this is from the Dartmouth project, and you can see really wide variation. Some problems in part of Texas. You can see spreading across the South. It's not randomly distributed across the country, but there's really a twofold variation in this, which is a lot. Here's a cost graph that's similar to the one that Mark showed, showing the parts of the country where Medicare spends the most per beneficiary. This is adjusting for differences in demographics. You can even adjust for differences in illness burden. There's still a 2- or 3-fold difference in the cost of Medicare treating a beneficiary in some parts of the country versus others. And if you do a quick regression, what's the correlation coefficient? It's negative. The parts of the country where we spend the most on Medicare beneficiaries are the parts of the country where they are the least likely to get high quality care. The measures of quality of care that are graphed here are things that are meant to be immune to patient characteristics. This is among diabetics, who's getting an eye exam, who's getting blood levels monitored, which heart attack patients are getting beta blockers or aspirin within 24 hours. These are low intensity, highly effective interventions that are rarely contraindicated. We graph them because they're immune to the types of arguments people make. I think of it as the reverse Lake Wobegon effect. Every provider's patient pool is sicker than average. This should be immune to that. And you, in fact, see a strong negative relationship. Now, why is there a negative relationship? That's really an open question. It would be nice to be able to say, I know the cause. One potential cause is if you look at the parts of the country where we spend the most and where beneficiaries are the least likely to get high quality care, the mix of the physician workforce is different. In those parts of the country, a greater share of the physician workforce are specialists relative to generalists. This doesn't mean that we are spending money for the sake of avoiding giving flu shots. This means that in parts of the country, perhaps people see more physicians and they get higher quality specialist care, but nobody says, gee, did you get your flu shot? Gee, have you had your mammogram? Now that begs another question. Why is it up to individual physicians to ask individual patients who may or may not remember whether they've had a flu shot? Shouldn't there be some centralized system that flashes a big warning, flu shot? We don't have that. And so basic care may fall through the cracks in parts of the country where people are seeing fewer generalists relative to specialists. But that's really speculation. We don't know for sure. This failure of coordination of care, or whatever is causing us to get lower quality care in the parts of the country we're spending the most, strongly suggests to me that we could move money around and get higher value care for the same amount of money that we're spending. And I think this within the US evidence is much more persuasive than cross-country evidence. And keep in mind that Medicare evidence is all from people with the same type of health insurance. It's all people covered by Medicare, and in fact, it's all people covered by Medicare fee-for-service. So there's no, how's Medicare Advantage doing relative to this? We don't know very well because we don't have as good data on the Medicare Advantage enrollees. But clearly this suggests that even within one insurance system, if the incentives aren't lined up to get high quality care, this kind of wild variation can persist. What are the consequences of not getting high value out of the system? Well, clearly we could allocate our health dollars differently and get more health because of them, and that should be a first order concern. But we could also perhaps allocate dollars differently between health and other goods. The fact that workers' wages are increasingly going to health care versus mortgage payments or food or anything else that families might need those resources for suggests that we're not getting the most out of our economy that we could, not only out of our healthcare sector. And it also interacts with the insurance coverage question, where the higher premiums rise, the more people fall into the uninsured pool. There's a particularly salient example in Massachusetts, where the reform there has focused pretty heavily on coverage, because in some ways coverage is easier to achieve. We know how to cover people. You mandate it, you subsidize it, you create a place for them to buy it, and people get insured. There's less attention paid there to the cost, not because people didn't care, but because it's a much gnarlier problem. And as a result, you see costs rising more quickly than they had expected. And that puts a strain on state budgets, which is a big problem, especially as revenues from other sources are falling. But people in Massachusetts are exempt from a mandate if their insurance premiums that they're quoted are too expensive relative to their income. This is for people who fall above the subsidy threshold but still below a certain percent of poverty. If insurance is unaffordable for them, they're not subject to the mandate. So as health insurance premiums rise, mechanically you undermine your coverage goal while at the same time you're straining state budgets. Okay, great, we all know inefficiency is bad. What are we going to do to fix it? Well, understanding the drivers of those high costs is the business of all of us health economists, I fear, for years to come. First, we know that a lot of the spending is attributable not to more physician visits or more hospital visits, but to more intensive treatment when there. It's the technology that an earlier question raised, but it's more intensive, it's more procedures that we have available to use, and it's using procedures that we have in more people. If you look at the average value of a new intervention, On average, a lot of these new interventions are life-saving and well worth it. We are much better off because there is an MRI technology than we were before the MRI. But if you look at the marginal use of the technology, the use in the next patient, the last patient, the MRI is booked 23 hours a day. Who do they put in that 24th hour slot? There on the margin, it may not be of particularly high value. That's very hard for people to react to in a way that promotes high value usage when none of the actors in the system, from the patient to the physician to the hospital, is rewarded based on allocating that technology to the highest value uses. Even if they could, the information to do so is often not available to individuals who certainly have very limited information about the cost, let alone the quality of the services they consume, but even to providers who may not know the effectiveness of different procedures when they want to give the best advice possible to their patients. The financing of healthcare is clearly a primary driver of the way we consume healthcare. On the public side, which I'm not going to spend much time talking about today, Medicare clearly reimburses for quantity of care, not quality, and there are all sorts of experiments underway, as Jamie talked about earlier, to try to reward higher value care, not just more care. There's also an inefficient use of resources among the uninsured. I'm going to talk about that in a little detail coming up. On the private side, though, the way we finance private health insurance is both wildly inefficient and regressive. A twofer. How does that work? It's neither fair nor efficient. If you get insurance from your employer, if your employer pays for part of your premium, that's paid with pre-tax dollars. If you buy your insurance on your own, or if you consume healthcare out of pocket, by and large, not entirely, there are always exceptions in the tax code, you pay for that care with after-tax dollars. Now, to a non-public finance tax economist, maybe that doesn't sound like such a big difference. Pre-tax, after-tax, who really pays attention to sales tax when buying something? Maybe it doesn't make that big a difference. In fact, for a typical person, when you add in income taxes and payroll taxes, you're talking about a 40 or 50% price difference. That means if your doctor's visit, your annual visit, is covered by your employer-provided policy, it's 50% cheaper than if you tried to get it on your own if it weren't covered by your employer policy. That means employer insurance policies are subsidized to have low cost sharing. And that's one of the main reasons that our employer-provided insurance looks so wildly different from every other kind of insurance that we buy. Think about your auto insurance. Think about your homeowner's insurance. You don't insure against routine expenses that are affordable to you otherwise. Insurance is about catastrophic risks, big expenses that you want to protect yourself against. Our insurance doesn't look like that because we subsidize it not to look like that. It's also really regressive. Why is that? Not having to pay taxes on something is worth much more to you when you're in a higher tax bracket. If you're in the 50% tax bracket and you don't have to pay taxes on $10,000, that's a $5,000 savings. If you're in the 10% tax bracket and you don't have to pay taxes on a $10,000 benefit, that's only a $1,000 savings. So right away, that's regressive. But it's worse than that because low-income workers are much less likely to have access to employer-provided insurance in the first place. So high-income workers, about 80% of people earning $75,000 and up are covered by an employer-sponsored policy, while only about 20% of workers earning under $25,000 are. This means the benefit is more likely to be available at all to high-income people, and high-income people get a greater value from the benefit than low-income people. This means the benefit is really distributed primarily to high-income people, with low-income people getting very little out of the system. So that certainly doesn't seem fair, and it's inefficient in the sense that I described before, where if you can get more and more things covered by your employer policy with low copayment, you're going to do that, and that drives us towards inefficient first-dollar coverage that really doesn't promote high-value care. It just promotes lower cost sharing in a way that may encourage some appropriate use of stuff that people wouldn't otherwise get, but may undermine higher value utilization of the dollars. So I would argue that our policy goals should be to reduce inequities, to make healthcare more affordable and more broadly accessible, and to get higher value healthcare out of the system. In order to evaluate the reforms that come across the transom, I'd like to outline a few principles for thinking about what makes a good insurance reform. The first I've hinted at already. Health is very different from health care, and health care is very different from health insurance. Lots of things affect health besides health care. If our goal as a society were to improve health and that was it, we probably wouldn't put that many more public dollars into insurance. We would put them into public health initiatives that would promote healthy lifestyles, that would promote access to good food and to exercise, that would give better childhood development, that would reduce smoking, that would reduce all sorts of health risks. And that would probably have a bigger impact on health than anything we can do in our health insurance system. So we should think about health reform more broadly. We don't just want to reform insurance, although we do want to do that because we spend a lot of money there. If we want to promote health, there are a lot of other policies that might be on the table, like augmenting food stamps or WIC. Insurance is different from health care. Insurance is fundamentally about risk. Now, that sounds completely obvious when I say it out loud, but next time you read the paper or hear a health policy debate, think about whether the speaker is confusing health care and health insurance. We don't need health insurance because health care is expensive. We need health insurance because health care is expensive and uncertain. We don't have insurance against buying a house because it's expensive, but it's under your control. It's not risky. We don't have insurance against college tuition. Similarly, you don't need to insure against small expenses, even though they're risky. You need insurance against potentially very big expenses. Developing a health condition that has lifelong health implications could easily bankrupt you and keep you from being able to afford the care that would be really life-saving. That's why you need health insurance. The corollary of that is that uninsured sick people do not need health insurance. They need health care. Now, that's a pretty controversial thing to say, although to an economist it sounds sort of tautological. If you are already sick and you are uninsured, you really need health care, but there's nothing to insure against. That's a little bit of a simplification. Of course, you could always get sicker, but it's hard to insure against the thing that has already happened. Insurance is against the unknown. So what you want to do is minimize the number of people in that circumstance. You want people to get insurance while they're healthy, and then some people fall ill, lucky people don't, and there's cross-subsidization among that pooled risk. A very different problem is faced by people who do buy health insurance when they're healthy and then fall sick, and are then worried that their insurer is going to raise their premiums. That is an undermining of long-run risk protection, where there's a strong regulatory role in guaranteeing that when you buy health insurance when you're healthy, you're buying protection not only against today's expenses, but against the risk of incurring much higher expenses in the future if you develop a chronic illness or something that's going to require expensive care for years to come. Those two groups sound kind of similar, but they're very different and they have very different policy needs. One is about regulating the insurance contract to protect people, to ensure they have real long-run protection. The other is about redistribution. Private health insurance fundamentally cannot redistribute money from rich people to poor people, or from people with low health risk to people with high health risk. Private insurance is about pooling people's risks among a group that has relatively similar risks ex ante. Once people have known very different expenses, private markets can no longer pool that risk, and what you can do for those people is social insurance. Think about it as a transfer, and there are many more efficient ways to do that transfer than we're doing it now. So anything that might undermine the current employer-based risk pooling should come with some sort of component to implement that social risk pooling that we'd like to have that redistributes money. We shouldn't expect private markets to do it. Social insurance need not be socialized, though. There's a difference between public provision and public production. You can subsidize somebody to go get a private good, or you can subsidize them in the form of a publicly provided good, where you give them health care directly or access to clinic directly, or publicly provided and produced health insurance. Or you can subsidize them to go buy private insurance. Either one is social insurance, but only one is socialized. A second point that I'd like to clear up is that covering the uninsured is unlikely to pay for itself. I hinted at this before. It would be nice to think that if we just covered the uninsured, they would consume healthcare so much more efficiently that it wouldn't cost anything on net. And there's some truth to that argument in that the uninsured disproportionately go to emergency departments for care that could have been more effectively provided through primary care or preventive care. But it's also true that the uninsured consume only about half as much health care as the insured. They underconsume health care. They have too little access to health resources. If you cover the uninsured, that costs money. It costs a little bit less money than you would have naively predicted because of that offsetting reduction in emergency department utilization. But that's small relative to the total increase in spending. Now, that doesn't mean we shouldn't cover the uninsured. It may be, and I believe it is, a socially worthwhile policy, not because we'll save money, but because we'll improve health. So you want to think about how we can spend that money to improve health the most, but if you want to cover the uninsured, you better build in some money to do it. It is not going to be cost savings. A corollary to that is that preventive care also, on average, doesn't pay for itself. Talking about investing in prevention is all the rage now, and it should be. Investing in prevention is a good investment in that it yields high health returns. But it doesn't lower costs necessarily. People live longer, healthier lives. They consume more health care over those lives. So you may be spending a little bit of money to get a lot of health, but you're not saving money. There's some exceptions. Flu shots for toddlers, in general, pay for themselves. The tricky part about this, the complication, is that most preventive care has good return on investment. It's cost effective. Some preventive care is not even cost effective. You spend a lot of money to save a life year. And what falls into each of those categories varies based on patient characteristics. The same screening test that might be highly cost effective for a 60-year-old might be very cost ineffective for an 80-year-old. In fact, it might even be that rare cost increasing, life reducing intervention. Some tests for cancer in 80 or 85-year-olds are unlikely to detect cancer that would actually be the cause of death of that person. Something else is likely to kill him first, and that's an unpopular thing to say, and one of the reasons that they don't like economists to interact with actual people. I'm trying to learn, but I'm slow. But knowing that the cancer is there, it is very hard for that patient to do nothing about it, even though doing nothing about it might be the most health-promoting thing to do. And once you go do something about it, that surgical intervention has a risk of mortality that's higher than the risk of mortality of the cancer that you found, but it's human nature to have a hard time not doing anything. So when we try to think about promoting prevention, it's a very heterogeneous good, prevention, and it's not even like you can put tests or procedures into one bin or the other bin. It very much varies on patient characteristics, and some of the complications that Jamie talked about in promoting high-value care through payment hinge on that complication of what's the right thing to do depending on the patient characteristics. Do we even have enough information on that? Third point I'd like to clear up is that lack of insurance is clearly not the only barrier to high-quality health care. If you look at the type of care that the insured get, there's overuse, there's underuse, there's misuse, just like Mark said. If you get the uninsured covered, they're going to get the same mix of care as the insured, which is better than they're getting now, but it's still a mix of overuse, underuse, misuse. So I don't think we can think that the solution to our quality chasm is just getting everybody insured. Once we get everybody insured, there'll be a very different distribution of resources, but we will have the same threats to high-quality care that we have now. The next misconception to clear up is that employees, in fact, bear the full burden of this privately obtained employer-based health insurance. I think there's this idea that if you just make employers pay more, we could cover more people and it wouldn't come out of public budgets and it wouldn't come out of individuals' budgets. That is a misunderstanding of where the money comes from. When employers pay for health insurance, it comes out of workers' wages. Maybe not instantaneously, maybe not one for one, and that makes it very hard for individuals to perceive this trade-off. It even makes it hard for employers to perceive this trade-off. Going back to my Washington policy days and talking with different stakeholders about reforms, I was constantly surprised at people's unwillingness to evaluate long-run trade-offs in this way. Now, part of that suggests maybe us economists don't have it right. If people consistently tell you something that's different from what your theory and evidence suggests, maybe you're not looking in the right place. And I think part of what employers were telling us was, you know what, tomorrow I have to pay for that health insurance, not my employees. But what the overwhelming body of evidence suggests is that in the longer run, employees bear the full burden of the benefits that they receive in the form of lower wage growth or even for some employees, less employment. If the cost of insurance rises high enough, especially for low-wage workers whose wages can't adjust downward because they're near the minimum wage or because there are other rigidities in labor markets, they risk unemployment as the cost of benefits rise. And we see that as health insurance premiums rise, wages grow more slowly, but also employers move people from full-time jobs with benefits to part-time jobs without benefits. And this is because of the difficulty of absorbing all of that increase in healthcare costs in workers' wages. There's also a very different problem with retiree health benefits, which has clearly been in the news lately with the woes of Detroit. That's a very different problem because retirees don't have wages to adjust. And what companies are complaining about there is that they have a big debt to their workers that's much bigger than they thought that it was going to be ahead of time, and that is always an unpleasant surprise. And it clearly threatens the viability of their business to have this much bigger debt. But in some sense, that's not about labor markets anymore, because those people have exited the labor markets. It's about a deal that was struck in a different time that now is having ramifications that they weren't prepared for. One of the sources of confusion here is that employer mandates and employee mandates, employer mandates and individual mandates are very different beasts. Employer mandates have effects on labor markets because employers adjust wages accordingly and adjust employment accordingly. Individual mandates do not have effects on labor markets because individuals are subject to those mandates whether they're employed or not. So they have very different effects not only on who's working where and at what wage, but they have very different effects on total coverage, and we want to separate them when we think about them. Now, I've argued that the employer-based system is driven in large part by the tax code. We subsidize you to get insurance from your employer. We do not subsidize you to get insurance anywhere else, for the most part. So that really drives people into the employer market, and it has some of these adverse consequences in terms of labor market rigidities and job lock and risk of losing your insurance when you lose your job. But it has some benefits too, and that goes back to the risk pooling discussion from earlier, that in fact, when you subsidize people to form a collective unit to buy insurance that isn't based on their health, which is their job, and there's some sorting across jobs because of health, but not all that much. You're forcing some risk pooling through this subsidy that might not occur in private markets. So if you think about reforming the tax treatment of employer-provided health insurance, you want to think about maintaining that function of risk pooling, but there may be much more effective ways to do that than through subsidizing employer-provided premiums, where you subsidize the most expensive policies for the highest income people with the most generous subsidy. That's the kind of trade-off you should think about. The last misconception that I'd like to clear up before going to a little bit of discussion about reforming the tax code, and I know I'm a little short on time, is high deductible policies are not the magic bullet for getting incentives lined up. A lot of what we've been talking about today is getting people exposed to more of their healthcare costs. And one of the reasons for that, Tom hinted at in his talk, that we know that when people face a lower price for their healthcare, they consume more of it. Now, again, non-economists bristle at this idea. It's not like people say, hey, MRIs are on sale, I'm going to go get me too. Nobody likes consuming healthcare. Nobody likes being sick. But we have evidence from a real randomized trial, one of the very few ones in social science, from the RAND health insurance experiment, which give us estimates of how much more people consume in healthcare when they have to pay less for it on the margin. And when people's prices of healthcare fall by 10%, they consume about 1% more healthcare, and that varies based on the type of service. That said, there are some types of care that people seem to underconsume. And that goes contrary to the idea that you should just let people decide for themselves. I think it's hard to hold those two ideas in your head at the same time in a logically consistent way. But there's evidence that people underconsume preventive care, for example, or that even $5 copayments on prescriptions undermine people's consistent refilling of those prescriptions. What all of that suggests to me is that you might want to promote the kind of high-value insurance that goes hand-in-hand with high-value health care. Imagine that an insurance company subsidizes you to go get a flu shot, because that is highly cost-effective, but charges you a different copayment for a particular test depending on if you fall into the group of people for whom it's of high value versus for whom it's of low value. That kind of value-based insurance design could go a long way towards allocating dollars to the highest value uses, but it doesn't look particularly like the traditional high-deductible health policy that goes along with the health savings account. It might look like it for some people, but it also might look different. So I think we want to have a flexible idea about what the highest value insurance product might look like. On the flip side, I don't think that a single payer system is the magic bullet either. I mentioned before that other countries are seeing rising rates of healthcare spending that are similar to those in the US, and in fact, other systems are moving towards a greater role of private payers, as Mark mentioned, from Canada to the UK. People think, oh, well, you could reap so much in administrative savings if you just went from our current system to a single-payer system where there are all these insurance companies. Well, some of the advantages that you would reap from moving to a more unified system you would also reap from moving to a more unified billing system and record-keeping system that still had multiple insurers, but where paperwork and data storage was harmonized. So that's part of the advantage you would get. Another part of the advantage really, I think, isn't an advantage. People suspect that Medicare spends too little on administrative costs. How could Medicare spend too little on administrative costs? Well, we have all of this evidence of potentially wasteful usage in Medicare, where private insurers are devoting some of their administrative resources to managing care. And people argue Medicare manages care too little. So that's not to say the private system is particularly efficient. I don't think that it is. But I also don't think that Medicare is the pinnacle of efficiency with which we'd want to benchmark private insurance reforms. So let's fast forward a little bit. Evaluating the effects of the panoply of reforms that Mark outlined, you'd want to think about what the different effects are on cost growth, what the different effects are on insurance coverage, and what the different distribution of burdens is. And those questions are sometimes addressed from different angles, but really interact. The way we finance healthcare affects cost growth. Growth of costs affects the number of people who are covered. The number of people who are covered affects the efficiency of resource utilization. So all of these are really intertwined. And they're all driven by the prices of different goods in the market. How much does it cost you to get health care through a private insurance policy versus out of pocket versus through Medicare? You want to think about the incentives in place in the system. And one of the reforms that's on the table is reforming the tax code, reforming the treatment of employer-provided insurance. And I don't have time to go through this in a lot of detail, but I just wanted to sketch out three of the major proposals for you. One is rolling over the current employer uncapped exemption into a flat deduction or a flat exemption, where no matter how much your health insurance costs, you get the same amount of money exempted from taxation. That was part of President Bush's proposal in 2007. Candidate McCain proposed a flat credit, which sounds fairly similar but has different distributional implications. That proposal was to replace the current employer system with a flat dollar amount. You get the same tax benefit no matter what your income is, no matter where you buy your insurance, and no matter how much it costs. That flatness of either the deduction or the credit means that people would no longer be subsidized on the margin to get a more generous health insurance policy. That has different distributional implications. The flat credit would devote more resources to the low end of the income distribution because it wouldn't be based on how much your income is. The value of the benefit wouldn't vary based on your income. Each of those can be designed to be revenue neutral, where you pick the credit amount or the exemption amount determines if you make money, if revenues go up, if revenues go down, or if they stay the same. You can dial it up or down accordingly. Another proposal that's on the table that candidate Clinton proposed at the time and that is now back in popular debate from Senate finance staffers and others is capping the exclusion. Right now, no matter how much your employer-provided benefit costs, you can take a tax exemption for that. You don't pay taxes even if it's a $100,000 policy. Now, if you cap that, you can cap it for everyone or you could cap it for only high-income people. And again, that has different distributional implications. But the key difference between a cap like that and the flat exclusion or flat credit is that people below the cap would face the same system that they face now, where an extra dollar of healthcare consumed from an employer policy would only cost you 50 cents. So for everyone below the cap, there would still be this subsidy of more and more care. But then for people above the cap, it would act as if it was flat. Your subsidy wouldn't go up no matter how much you spent. So it's a little bit of a hybrid. That's clearly a money maker. When you cap a benefit that was otherwise uncapped, you collect more in tax revenues. Now, the distributional implications hinge on why people's premiums are high in the first place. It's easy to sort of caricature this and say it's the gold-plated policies, it's people who have, masseuses and things covered by their insurance plan, and why should uninsured and low-income people subsidize that luxury care for high-income people? The generosity of your policy is one reason that your premium might be high, but there are a lot of other reasons. That geographic variation that we saw, the size of the group, state regulations. Are you in a state with different rating requirements or different benefit mandates? All of those drive variation in premiums. Some of that variation you want to accommodate, I think, and some of it you don't want to accommodate. Do we want to continue to subsidize inefficient use of care in some parts of the country just because they historically have higher spending? Maybe not. Do you want to continue to subsidize places that have higher cost of living relative to others? Maybe, but there are lots of provisions in the tax code that don't take into account variation in the cost of living, and it's not clear that you want to do that through the tax code. So I would argue that reforming that system is a necessary component of a broader reform, but that it's not enough. If you're going to reform that treatment, you need to provide some other way to bolster risk pooling so that individuals don't face higher costs just because they fall ill, and so that everyone has access to a policy that he or she can afford. One way you might do that, and I'll just plant this seed and stop there, is you could provide risk-adjusted vouchers or credits to people, where individuals receive a greater subsidy, maybe if they're low income, but also if they face higher health costs. And insurers are then paid their expected cost for every enrollee. What this would do is remove the incentive for insurers to select healthier risk people. If insurers are getting paid the marginal cost of every enrollee they have, maybe some of them will specialize in treating high-cost people rather than specializing in avoiding enrolling high-cost people. If insurers are paid that way, I think you really promote that value-based insurance that I talked about. The problem with just having people pay their expected costs is that we don't want people who fall ill to then have higher health insurance premiums. So their subsidy has to scale up accordingly so that the individual isn't facing that risk, but neither is the insurer. That social insurance would subsidize high expected cost people relative to low expected cost people in a way that would promote both risk pooling and insurance innovation. So that's the kind of direction of reform that I think would make a great complement to making the tax code more efficient and more fair. And I'll stop there and take questions.
I've sat here all day and I haven't heard anything at all about price structures. The issue, there are different prices for different people. And so if you don't have insurance, you get to pay the highest price. If you have insurance, your insurance company or Medicare has negotiated for much lower prices. And so in all of these proposals to have essentially catastrophic insurance, people who get up before they get to the catastrophic levels have been consistently paying higher prices for the health care. Maybe that's not part of the greater debate, but it certainly, it always put the kibosh on Bush's proposal to me that we go to a catastrophic insurance policy with health savings plans.
But that's a great point. I'm glad you bring it up. Having insurance confers several advantages. One, it's financial protection against risk, but also once you're insured, you get access to your insurer's negotiated rates, where if you're uninsured, you're paying potentially much more than insured people for the same services. And that's not transparent right now, but as Jamie said, price transparency is for other people. But if there were price transparency, we would know more about that. But it's one of the real advantages of having access to an insurer's negotiated rates. Even if you're in the deductible part, you still get the negotiated rates. That's not particularly well advertised, and it's also one of the benefits of a higher deductible policy that HSAs were trying to capitalize in leveling the playing field through the tax code. If out-of-pocket costs, even if you get your negotiated rate, you're still paying with after-tax dollars, that's a real disadvantage. And the goal of the high deductible policy HSA structure was to let people pay those out-of-pocket costs at their insurer's negotiated rates and with pre-tax dollars. That said, I think you'd want to apply that kind of benefit of getting to pay with pre-tax dollars to a more flexible array of health insurance policies, not just the particular kind outlined in the tax code, but that negotiated rate access is key to being able to afford care so that during your deductible period, you're not burning through costs.
Hi there, my name is Don Levitt, and you're talking a lot today about the tax code. You might be aware that The Congress will be looking into tax-exempt hospitals pretty soon, making sure that they fully earn their tax-exempt status. You may also be aware of 501, Section 501, in which that was back in '86 when tax-exempt insurers like Blue Cross and Blue Shield were being investigated to make sure they earn their tax-exempt status. Was wondering if you might be able to comment on how an insurer can earn that tax-exempt status, and if you know much about 501c9s and 501c8s.
All I know is 501c3s, so no, I'm sorry, that is actually a little outside my area of expertise. It's clearly very important to align in the tax code incentives not only to get insured, but the way that people provide care, but I really don't feel knowledgeable enough to comment on those provisions.
Last question.
Often,
hopefully it's one I can actually answer.
You know, health policy is, I'll throw you a lob. Health policy is frequently a reflection of our society's values. And looking at the numbers, our society values spending a lot of money on life-sustaining measures. When you look, something that people haven't commented on, and I'd appreciate your input, is dollars per life year gained. And if you compare the United States to, say, the NHS or other countries on your diagrams, we're 2 or 3 times higher. And I wondered how that would kind of fold into this healthcare debate.
It really is, the whole debate hinges on values, just the ones that you're raising, in that, of course, we're all in favor of eliminating waste, fraud, and abuse, and eliminating spending that actually harms people. But very quickly you get to the much tougher choices that require trade-offs about how much you're willing to pay for each person's health. And rationing is a really dirty word in this context. I think, you know, if you ask people, are you in favor of rationing, everyone would say no. But de facto, healthcare is rationed, in that we only have 100% of GDP to spend. And thanks to the miracle of modern medicine, we could spend a virtually unlimited amount on things that might improve people's health. But at what cost is the question. And who do you want deciding, or what mechanism do you want to be the one that allocates scarce resources? Do you want it to be purely ability to pay? I think we've decided as a society that that's not reasonable, that we think that people, regardless of income, are entitled to a certain minimum benefit. Now, I don't know what that minimum benefit should be, and that's open to debate, but I think we all agree it's substantially above nothing. Are we willing to ration care just by waiting in line? That seems untenable, and it also seems untenable in the countries that started off with it. That kind of waiting in line is eroding a bit. Are we willing to have a government entity decide this procedure will pay for this person, this procedure will pay for this person, but not this and not that? I think we're not ready for that as a country either, that we voted against that. So there's some sort of hybrid where public dollars guarantee a floor of benefits. And that floor may be based on effectiveness of the care, and that requires better information on comparative effectiveness, and people are resistant to that better information because they fear the road to sort of long-run, nice-like allocation. On the other hand, without that information, I don't think we have a good way to allocate that floor in a way that's equitable. And then I think we're never in this country going to say that people who have the resources to consume above that floor aren't free to do so. The question is, can we finance that floor in a way that's efficient, that the floor level guarantees a quality and length of life that we find acceptable? And that's the real challenge.
Well, thanks very much.
Thank you.
I would just like to take a couple of minutes to thank the people who've made this conference possible today. First of all, to our speakers, who their normal research in some cases can be very technical, and to come to an audience and take the time today to make your material understandable to such a heterogeneous group. It's very highly appreciated that you took the time to do that. I would also like to thank the Health Policy Forum members who you've seen listed up here for sponsoring this effort, and I hope this is the start of a larger effort in Houston to get the different members of the healthcare industry around the table and looking at solutions to our healthcare reform problems that we're facing. And I'd also like to thank the event staff here at the Baker Institute and my research analyst, Mara Short, who I think some of you have been emailing with because they have done a tremendous job in terms of getting this conference to perform smoothly and to get everyone here and get the news out on this. And last of all, I would like to thank the audience for coming here. You have been a wonderful audience. I appreciate the questions, extremely thoughtful. And the speakers were telling me at lunch that they were impressed with how thoughtful the different questions and comments were. And so we welcome you back, and we'll be back here 2 years again from now, and we'll be having some other health policy conferences along the way as well. So thank you for coming, and please, keep in touch and give us your feedback on what you thought. Bye.